Hello everyone. Welcome to the last lecture of the journey we had embarked upon 2-3 weeks back to learn all about tuberculosis, at least clear our concepts, know the basics, and have a basic idea, overall idea about childhood tuberculosis. So today is the last lecture, that is the drug-resistant tuberculosis, a relatively complicated topic among all the topics we have encountered. The outline of today's lecture will be: we'll learn about the definitions, we'll learn about the epidemiological markers of drug-resistant tuberculosis, we'll know the methods of testing, we'll know how to manage the drug-resistant tuberculosis, and we'll look for some of the special considerations. So now coming to the most important slide in drug-resistant tuberculosis, that is the definitions. It usually comes as an MCQ. It's asked frequently in the examinations also. So what are the definitions? First, coming to monoresistant tuberculosis. What is monoresistant? Monoresistant means one first-line drug only. No other drugs. In any first-line drug, if it is resistant, it is called as monoresistant. Second is isoniazid resistant tuberculosis, that is resistant to isoniazid but sensitive to rifampicin has been demonstrated. That means the tubercle bacilli are sensitive to rifampicin but resistant to isoniazid. That is called monoresistant tuberculosis. Why the sensitivity to rifampicin is important? Because if the bacilli were rifampicin resistant also, it would have been called multi-drug resistant directly. So that's why it's important to document resistance to isoniazid but sensitivity to rifampicin simultaneously in order to call it as isoniazid resistant tuberculosis. What is polydrug resistant tuberculosis? Polydrug resistant tuberculosis means more than one first line drug patient is resistant other than H, that is isoniazid and rifampicin. That means the other first line drugs, that is pyrazinamide, butol, or streptomycin, if more than one other first line drugs the patient is resistant to, it is called polydrug resistant. What is rifampicin resistant TB? It is self-explanatory. That means resistance to rifampicin is present with or without resistance to other drugs, and if rifampicin resistance is present and isoniazid resistance is also present, it is called as multi-drug resistant tuberculosis. It may or may not be associated with resistance to other drugs. New entity pre-XDR, that is pre-extensively drug resistant TB. What is it? It means multi-drug resistant TB or rifampicin resistant plus fluoroquinolone resistance. And what is extensively drug resistant TB? Pre-XDR group A drug. What are the group A drugs? Well, learn a bit. What is extensive or advanced TB disease? It refers to bilateral cavitary disease or extensive parenchymal damage. And what is severe extrapulmonary TB? It refers to miliary TB, tubercular meningitis, extrapulmonary tuberculosis except lymph node tuberculosis. So these are the definitions. If you want, you can pause and take a note of these because it's very important. So what is exactly monoresistant? Monoresistance means isoniazid, rifampicin, pyrazinamide, ethambutol, any one of the first line drugs, if it is resistant, it is called as monoresistant. What is isoniazid resistant? Isoniazid resistance means isoniazid resistant plus sensitive to rifampicin. That is very important. What is polydrug resistant? Any more than one drugs except isoniazid and rifampicin. That means which drugs are left? Pyrazinamide and ethambutol are left. So it is called polydrug resistant. What is meant by rifampicin resistance? Rifampicin resistance means resistance to rifampicin plus or minus, that is with or without other first-line drugs. And what is multi-drug resistance? Multi-drug resistance means rifampicin and isoniazid, that is a must, with or without other drugs. What is pre-extensive drug resistance? Pre-extensive drug resistance means multi-drug resistance plus fluoroquinolone resistance. And what is extensively drug resistant? Extensively drug resistant or extensively refers to multi-drug resistant plus fluoroquinolone, that is pre-extensively drug resistant plus any of the group A drugs, that is called extensively drug resistant tuberculosis. So what is universal drug sensitivity testing? Universal drug sensitivity testing refers to universal access to rapid drug sensitivity testing for at least rifampicin, where possible INH should be provided to all the cases. It also includes drug sensitivity testing for fluoroquinolones for all the patients with rifampicin resistant TB. That means any patient who is diagnosed to have tuberculosis should undergo rapid drug sensitivity testing for rifampicin and if possible INH, and any rifampicin resistant TB, if it is diagnosed, it should additionally be provided facility for drug sensitivity testing for fluoroquinolones. What are the epidemiological markers of drug-resistant tuberculosis? Any history of contact with an MDR-TB suspect is an epidemiological marker. Any previous poor treatment, what is meant by poor treatment? Inadequate drugs, inadequate doses, inadequate duration, or lack of adherence to treatment. These are epidemiological markers of drug-resistant TB. If the patient is not responding to therapy, if there is a disease occurrence after previous treatment, all the tuberculosis among children living with HIV, and contact someone who is dying of tuberculosis. All these are epidemiological markers of drug resistant tuberculosis. What is meant by epidemiological marker? That means if these history or clinical features are present in a particular patient who is diagnosed to have tuberculosis, there is high chance that the patient might actually be a case of drug resistant tuberculosis. So the importance of drug sensitivity testing assumes more important role here. It should be carefully evaluated. So how do we confirm drug resistant in a case? Confirmation of drug resistance always has to be microbiological. It may be genotypic resistance and it may be phenotypic resistance. What is the difference between a genotypic and phenotypic resistance? Genotypic resistance means that particular gene or mutation for resistance is present in that bacilli. Phenotypic resistance means whether that bacilli actually responds to the drug. Both these are different, because suppose the mutation or gene for resistance is present, but due to some reason the patient or the bacilli is still killed by the drug. That means that genotypic resistance is not expressed. So that is the difference between genotypic and phenotypic resistance. Confirmation of drug resistance, for that we have to take appropriate body samples, which is crucial. If we don't take appropriate and adequate samples, the resistance may be missed. The appropriate testing is nucleic acid amplification test or line probe assay or culture and drug sensitivity testing. Clinically diagnosed drug resistant TB and probable MDR-TB. These are the two broad headings under which we will classify a particular patient after the resistance testing. And in a presumptive drug resistant tuberculosis patient, if all efforts for microbiological confirmation have failed or confirmation is not possible due to inaccessible specimen, but the clinical probability of it being a drug resistant tuberculosis is high, that is failure of adequate first line therapy and or close contact of a proven MDR-TB case, and there is no alternative diagnosis or explanation for non-response of the patient, it may be treated as a clinically diagnosed drug resistant TB, which is called as probable MDR-TB. In such situations, the drug regimen can be decided based on the drug sensitivity pattern of the drug resistant tuberculosis contact, which is a likely source case where available. Moreover, the patient considered to have probable MDR-TB should be presented to and discussed with the DR-TBC committee for confirming the decision and to treat in consultation with a pediatrician. That is important to remember. So, who is a probable MDR-TB among children? Drug-resistant tuberculosis is clinically suspected strongly, but the bacteriological confirmation is not technically feasible or negative. That is called as a probable MDR-TB, because clinically it is highly suspected, but the bacteriological confirmation is not possible. So what are the criteria for that? Signs and symptoms of active TB disease must be present in the child with a history of close contact with a known case who is a MDR-TB case, or a close contact with a person who died on TB treatment, or a close contact with a person who failed TB treatment, or non-response or failure of first-line drugs, and last but not the least, previous treatment with second-line medications. If signs and symptoms of active TB disease with any one of these is present, it is called as probable MDR-TB. And in addition to that, an appropriate specimen, if it fails to demonstrate mycobacterial tuberculosis and thus the resistance pattern cannot be confirmed, that is known as a culture negative TB, or access to the specimen is not easy, that also has to be considered as a case of probable drug resistant TB. Suppose you are suspecting a case of tubercular pleural effusion. So the appropriate sample would be pleural fluid. But due to some reason, you are not able to get the pleural fluid. So in that case, the patient has to be considered a probable multi-drug resistant tuberculosis. And next, obviously, we have to know who is a confirmed drug resistant tuberculosis. A confirmed drug resistant tuberculosis is a case where the results suggest drug resistance from an NTEP quality assured culture or drug sensitivity laboratory and NTEP endorsed testing method. What are the NTEP endorsed testing method? That is NAT, LPA and culture. So what are the methods of drug susceptibility and drug resistant testing? Methods of drug susceptibility and drug resistant testing can be direct, which is performed on a sputum specimen, or indirect, which is performed on a culture isolate. So there are mainly three types of testing available. One is nucleic acid amplification test, another is line probe assay, another is expert MTB XDR. So nucleic acid amplification test can be smear positive or smear negative. It can also be performed on extrapulmonary specimen. It can detect DNA even with few copies. It detects Mycobacterium tuberculosis as well as gives additional information about the rifampicin resistance, and it takes about 2 hours. On the other hand, the line probe assay, it consists of two types. First line probe assay, testing for the first line drugs, that is HRJD. Second line probe assay, you test for the second line drugs like fluoroquinolones or group ABC drugs. It detects when DNA copies are more than 10,000 per ml, that is only smear positive cases, it can give the result. It is slightly longer taking, so about 72 hours it takes, and genotypic drug sensitivity on an isolate from a culture should be performed. And last but not the least, the expert MTB XDR. It is a semi-quantitative nested PCR. It detects the mutations associated with resistance, and it takes about 90 minutes. So among these tests, the fastest is the expert MTB XDR. It takes about 90 minutes. So what is growth-based phenotypic drug susceptibility testing? So it is used for long-term follow-up of patients on DRTB treatment. That means if a patient is diagnosed as a case of drug-resistant tuberculosis, for follow-up of that patient, we have to do growth-based phenotypic drug susceptibility testing. It also detects early recurrence in both drug-sensitive and drug-resistant tuberculosis. It also determines the critical inhibitory concentration of various drugs, and automated liquid culture systems like Bactec MGIT 960 or Bactalert or Versatric etc. are used. The solid media mainly used is Lowenstein Jensen media or LJ media, and MGIT is also preferred, that is Mycobacterial growth inhibitory tube. So some important notes to know before microbiological testing in drug resistant tuberculosis. The first and most important thing is always two specimens have to be sent from every patient. One has to be sent for nucleic acid amplification test and another has to be sent for culture. If the culture becomes positive, on that sample the line probe assay has to be performed. That is to be known. Second thing is the specimen has to be transported immediately after collection in cold chain with triple layer packaging. The extrapulmonary TB samples like CSF, pleural fluid, etc., should not be collected in formalin. It should also be always be collected in a sterile conical falcon tube. AIC, that is airborne infection control measures, must be followed at all times. Rifampicin resistance on NAT, if it is revealed, then the patient has to be undertaken for first line probe assay and second line probe assay, and following that, liquid culture drug sensitivity testing has to be performed. Rifampicin resistance with very low level Mycobacterium tuberculosis, if it is detected, it has to be always confirmed by a repeat specimen with nucleic acid amplification testing. Rifampicin resistance is absent, but isoniazid resistance is present in first line probe assay. Then what has to be done? Then second line probe assay with LC-DST has to be performed. So now we will learn what is the algorithm or what is the format we follow if we want to evaluate a particular childhood TB tuberculosis patient who is suspected to have drug resistant tuberculosis. So if a childhood TB patient comes to you, first thing that you look for is whether the drug resistance or drug sensitivity status of that patient is known or not, because if it is known, there is no confusion. For example, if the patient is a known or confirmed case of drug sensitive tuberculosis, then there is no confusion. We just treat the patient as a case of drug sensitive tuberculosis. Likewise, if the patient is a known case of drug resistant tuberculosis, then there is no confusion. We just treat the patient as a drug resistant tuberculosis. But suppose the drug resistance or drug sensitivity status of the patient is not known. In that case, what we have to do? In that case, we have to rely upon the contact of that patient. We have to first see whether the patient's contact, whether there is contact with an infectious TB patient or not. Because if the contact history is present, we can trace the contact or trace the source and ask whether that source is a case of drug-resistant tuberculosis. Because we learned in the epidemiological markers of drug-resistant tuberculosis, if the patient has a positive contact history with a source who is a drug-resistant tuberculosis, then there is high chance that this particular patient may also be a case of drug-resistant tuberculosis. So if the source of this patient is a drug-resistant tuberculosis case, we have to consult the pediatrician. We have to re-attempt the sensitivity testing with a more appropriate specimen, and even if it requires invasive testing like bronchoalveolar lavage, we may have to undertake that also, because there is high chance that this patient is a case of drug resistant tuberculosis. And if still no information on resistance pattern is seen, then treat according to the drug sensitivity testing of source case as probable DRTB. That means even after performing this test, if we get no information, then we have to treat this patient according to the sensitivity pattern found in this patient, because this is the source, means the organism present in this patient has transmitted to this patient. So the organisms that have responded to the drugs in this patient may cause clinical improvement in this patient also. So we have to treat this patient according to the sensitivity pattern in this patient. On the other hand, if the drug resistance or drug sensitivity testing or status of the source case is also not known, or if the source is a case of drug sensitive tuberculosis actually, then what do? Then we have to do DRT or DST, that is drug resistance testing or drug sensitivity testing of the child or source specimen. That means we have to do the test of this patient actually whose test has been not been done or the status is not known, and we have to test this patient also by NAT and MGIT. And if DRTB is revealed in this test, then we treat as DRTB. If DSTB, that is drug sensitive TB, is revealed in this test, we treat as drug sensitive tuberculosis. But at any point of time, if there is any poor response to treatment, we switch here. That means we have to try testing with a more appropriate specimen, and even if it requires more invasive testing. So now coming to, I think, the most complicated slide, or the most difficult looking slide in all of drug resistant tuberculosis. But if we follow a systematic approach and if we understand why it has been done or how it has been done, then I think we may be able to understand the uh, this complex slide or this complex algorithm, and we will definitely will be able to understand. So all the TB patients have to be taken for nucleic acid amplification test, because this is the mainstay of diagnosis. Likewise, all presumptive TB or key population also have to be taken for nucleic acid amplification test. So whenever a patient is taken for nucleic acid amplification test, simultaneously two samples are taken, we learned just now. So first sample that is taken for nucleic acid amplification, suppose rifampicin resistance is not detected, that means the report comes Mycobacterium tuberculosis detected, rifampicin resistance not detected. Then what is this case? This case is most probably a case of drug sensitive tuberculosis, and we have to start treatment with first line drugs. So drug sensitive tuberculosis regimen has to be followed, and as we discussed, all the cases of tuberculosis in which microbiological proven proof is there, we have to take the sample for first line probe assay. So first line probe assay, it takes 72 hours. Suppose first line probe assay, we have to see INH resistance is detected or not, because we have already seen that the rifampicin resistance is not there. So we have to see INH resistance is detected or not. If INH resistance is detected, what is this? This is a mono-resistant tuberculosis. So we have to stop the drug-sensitive TB regimen and start the therapy for monoresistant TB or INH resistant TB. But if INH resistance is not detected in this first line probe assay, then what is it? It is a drug sensitive TB. So if it is not detected, we have to continue the drug sensitive tuberculosis regimen. But if INH resistance is detected, then next what we have to do? We have to do the reflex testing with second line probe assay and liquid culture drug sensitivity testing for pyrazinamide, moxifloxacin, linezolid, and clofazimine. These are the second line drugs. We have to do reflex testing, and we have to start therapy with INH mono or poly drug resistant tuberculosis regimen, because INH resistance was detected here but rifampicin resistance was absent. So this is a case of mono resistant TB to INH. So we have to start treatment for INH monoresistant TB or INH polyresistant TB, depending upon what other drug sensitivity has been there. Suppose INH and pyrazidamide resistance is there, so this will be INH polyresistant TB. Suppose no other drugs resistance is detected, only INH resistance is detected, so this will be INH monoresistant TB. And while undertaking treatment, we have to always look if there is any additional resistance, or there is any intolerance, or if there is any non-availability of any drug in use, or emergence of exclusion criteria at any point. Because if any of these happen after this or after this, we have to modify the treatment. We have to modify the INH mono or polydrug resistant tuberculosis as per the replacement table. There is a replacement table where we can replace drug for drug. So if any of these contraindications like exclusion or exclusion criteria, or non-availability or intolerance or additional drug resistance, anything emerges, we have to obviously modify the modify the regimen. And at any point we are giving treatment here, we are giving treatment here. At any point, if the patient does not respond, then we have to come back to NAT. We have to repeat the nucleic acid amplification test, and then we have to follow whatever report comes. Likewise, if the drug resistant tuberculosis INS resistance is detected here and it becomes a drug resistant tuberculosis, then also we have to when if the patient is not responding, we have to go back to NAT. So all this has to be done from the first specimen which is tested at the nucleic acid amplification test site. So suppose in the first specimen rifampicin resistance was not detected, what do we do? Learned here. Suppose rifampicin resistance is detected, then what do we do? Rifampicin resistance is detected means this patient is a case of rifampicin resistance TB, or it can also be called as multi-drug resistant TB depending on the presence or absence of INH resistance. So then what do we do? Then we do first line probe assay, second line probe assay, LC-DST, all the three tests. Important point to note here is that in this case also we did all the tests, FLLPA, SLLPA and LC-DST, and this case also we did FLLPA, SLLPA, LC-DST. That means irrespective of rifampicin resistance detected or not detected, all the patients of TB, all the patients of TB that are nucleic acid amplification test or microbiologically confirmed have to be taken for first line probe assay, second line probe assay and LC-DST. That is the universal drug sensitivity testing that we talked about brief time ago. So after this test, the second specimen is tested at CNDST lab, that is culture and drug sensitivity testing lab, according to this algorithm. So as I told, every patient diagnosed to have tuberculosis has to give two samples. One sample is tested at the NAT site, another sample is tested at the CNDST lab, and depending on the report of those tests, the treatment has to be undertaken. So after we did these tests, suppose we did these tests and we are awaiting results. So next what we will do, we'll check if line probe assay results are available or not. Suppose line probe assay results are not available, then what do we do? Suppose results are not available, it takes 72 hours, so we don't know, or we have no idea whether multiple drugs are resistant in this case or only rifampicin resistance is this case. So then we have to see what are any other exclusion criteria for shorter regimen. Is there any exclusion criteria present for shorter regimen? If no exclusion criteria is present for shorter regimen, we will give shorter regimen. If exclusion criteria is present for shorter regimen, then we'll not give shorter regimen, we'll give longer regimen. So that is here. If no exclusion criteria is present, we'll give shorter oral bedaquiline containing regimen. If exclusion criteria is present, we'll give longer oral MDR-TB regimen. All this has to be done if LPA results are not yet available. But at any point of time, if LPA results are available, then depending on the report of those tests, we have to give the treatment. But like we did in this case, we started the drug resistant tuberculosis therapy here, but we continuously monitored whether any additional resistance or intolerance or non-availability or exclusion criteria developed or not. Like that, even if the report is available, we have to continuously monitor whether any resistance or additional mutation, all those things are detected. Because if at any point of time additional mutation, additional resistance is detected, the patient will not be able to respond to a shorter regimen. The patient will take a longer regimen to respond. But if those things do not appear, the patient may suffice to have a shorter regimen. So that is the important thing. So what did we do here? First, we detected rifampicin resistance by the NAT. Then we did all these tests, that is FLLPA, SLLP and LC-DST. Depending on the reports of those tests, we have to give the therapy. If results are not available, we have to look for the exclusion criteria for shorter regimen. If exclusion criteria is present, that means we cannot give shorter regimen. So we have to give longer regimen. On the other hand, if exclusion criteria is absent, then we can give shorter regimen. So we gave shorter regimen. If reports are available, also we'll give those regimens, but longer or shorter has to be decided depending upon whether any additional resistance, additional mutation, all those things are detected. Because if all those risk factors, extra risk factors are present in this case, the patient will require a longer therapy. If no additional risk factors are there, the patient may suffice to have a shorter therapy. And while on treatment, we have to always continuously look for additional resistance, intolerance, non-availability, like we looked for in this case. And if at any point of time these things are detected, like we did here, we have to modify the regimen as needed. So this is the algorithm for evaluating a patient who is suspected to have drug resistant tuberculosis. If you look superficially, this this algorithm looks very complicated, but if we follow stepwise and understand the reason why it has been made so, it will not be that complicated. So what did we do? First, the patient will go to a specimen collecting center, and two specimens will be collected initially, preferably in conical falcon tubes, packaged in triple layer and transported immediately to a nucleic acid amplification test facility in cold chain. And the patient ID and the test ID has to be generated in mixture. That is the first step that has to be done. Second thing is whether the first specimen has to be taken for NAT. We learned just now, first specimen has to be taken for NAT. If MTB is detected, rifampicin resistance may be plus or minus. The second specimen has to be taken to C and DST lab, because we learned that the first specimen has to be evaluated at NAT lab and the second specimen has to be evaluated at culture and drug sensitivity testing lab. And the NAT result will be updated and the test ID for tests is expected at the CDST lab and is created in mixture. Third, we go to the C and DST lab, because first sample is evaluated at NAT facility, second sample is evaluated at C and DST facility. NAT facility does the NAT test, C and DST facility does the first line probe assay, second line probe assay and liquid culture DST. So second specimen has to be taken for first line probe assay, second line probe assay and further DST as applicable. If the patient is mere negative, liquid culture and LPA may be undertaken and the test results are updated in mixture and communicated to the referring facility, the patient and the physician. So that is the diagnostic algorithm of a drug-resistant tuberculosis. Now coming to the management of drug-resistant tuberculosis in children. So what are the basic principles of managing a drug-resistant tuberculosis? So first principle, we have to always include at least 4 to 5 effective medications from group A and B to which the Mycobacterium tuberculosis is known or likely to be susceptible. That means group A and group B drugs have to be included always, and the patient always has to take at least 4 to 5 effective medications. Effective medications means the patient, what are the effective medications? Effective medications are medications to whom the resistance has not been demonstrated. That is the effective medications. For example, if a particular patient is rifampicin resistant, we cannot give rifampicin, we can give other drugs. If a particular patient is INH resistant, we cannot give INH, we can give other drugs. So other drugs become effective medications, and we have to always include medications from group A and B to which the MTB is known or likely to be susceptible. What is the second principle? Do not add a single drug to a failing regimen to avoid amplification of resistance. Never add a single drug to a failing regimen. Always it is multi-drug therapy. Next is strict monitoring. As these are toxic drugs, they may have a lot of side effects, and the patient is a drug resistant tuberculosis, so anyway it is a complicated. So we have to always monitor clinically, radiologically, and monitor the culture response also, preferably by a pediatrician or any expert available linked to the drug resistant tuberculosis center. So important thing to remember for us here is that pediatrician is also an expert. So we may not or need not always seek the help of a higher expert always, if the patient is responding, that too. If the patient is not responding, then we may seek the help of another superior expert for the betterment of the patient. And it is never ever wrong to seek a second consultation actually. So 5 to 18 years and weight more than 15 kg, both are eligible for shorter and longer oral regimens. and pre-treatment evaluation is valid for 1 month. That means all the blood tests or baseline tests that you do before starting a particular patient on drugs and resistant tuberculosis regimen are valid for 1 month. That means if any change in regimen is required within 1 month of starting therapy, it can be done by taking the pre-treatment evaluation into consideration. That is valid for 1 month. Last thing is 6 monthly culture till 2 years after completion among the symptomatic patients. Patients who are symptomatic to begin with, the patients have to be taken for therapy of drug resistant tuberculosis, which may last for any time between 12 to 20 months. So 1 to 1.5 years or 1 year and 8 months, the patient may be under treatment. After completion of that treatment, for next 2 years, 6 monthly cultures have to be done. And last is active drug safety management and monitoring, that is ADSM treatment initiation form has to be filled up for all. So till now we have seen a lot of references that group A, group B. So what are those? So any multi-drug resistant tuberculosis mainly contains three groups of drugs, that is group A, group B and group C. Like we learned in the first principle of multi-drug resistant tuberculosis management, we have to always include drugs from group A and group B, that is 4 to 5 effective drugs. Group C is plus minus. Principle was that we have to always include drugs from group A and group B, never group A alone or group B alone. Group C is plus minus. So what are the group A drugs? Group A drugs are levofloxacin or moxifloxacin, bedaquiline and linezolid. What are the group B drugs? Mainly two drugs, clofazimine and cycloserine or terazidone. And what are the group C drugs? The group C drugs are ethambutol, delamanid, pyrazinamide, imipenem-cilastatin or meropenem, amikacin or streptomycin, ethionamide or prothionamide, and para-aminosalicylic acid. So these are the group A, B, and C drugs. I know there are a lot of drugs and we may not be able to remember, but at least group A and group B, these five drugs we have to remember. And to understand how the drug-resistant tuberculosis management is done or what drugs are given, I have color coded these. So group A from now on we'll understand that this is red, group B is yellow and group C is green. Why red and yellow I have kept? Because group A and group B always has to be included. So that is group A and group B and group C drugs. So now we will see how these drugs are given in a case of multi-drug resistant tuberculosis or how these drugs are chosen. So these are our drugs, and assume that a case or a child has been diagnosed as a case of drug resistance. We don't know what resistance, but particular drug the patient has resistant to. So first we'll see if there is INH mono or polyresistance, because imagine the scenario, suppose the patient has INH mono or polyresistance. That means the patient is resistant to INH. And remember the criteria to call a case as INH resistance, INH monoresistance, there was an additional criteria that rifampicin sensitivity must be demonstrated. That means this patient is INH resistance but rifampicin sensitive. That means this patient only has resistance to one drug, that is H. So the usual treatment that we give in tuberculosis, that is what? HRJD. So in among those drugs, what drugs we cannot use? We cannot use INH here, that is H, because the patient is resistant. So from HRJD we will switch over to what? RZE. So we will give RZE plus, to replace INH we have to add levofloxacin, that is a first group A drug, because group A drug is a must. So we have to give rifampicin, pyrazinamide and ethambutol. Why? Because the HRJD became RJD because H was resistant and we added one drug to replace one drug. So levofloxacin, and this treatment has to be undertaken for 6 to 9 months. Where 6 months, where 9 months, we'll learn in a bit. But by default, you remember that the 6-month RJD plus levofloxacin is the regimen used for INH monoresistance or polyresistance cases. On the other hand, if a particular patient is diagnosed to have MDR or RRTB, that means the patient is diagnosed to have rifampicin and INH resistance, or mainly rifampicin resistance, then what do we do? Because this becomes complicated. So when a patient is diagnosed to have rifampicin resistance, we first classify the patient into two groups, whether it is a pulmonary non-severe extrapulmonary case or this is a severe pulmonary or severe extrapulmonary case. So look at the two groups again. First, pulmonary except extensive or disseminated, that means all the pulmonary drug resistant TB from which extensive and disseminated, that means severe cases, have been removed. and non-severe extrapulmonary cases. That means this is resistant TB but not that severe. This is that category. Second category is extensive disseminated pulmonary. That means the group that has been removed from here is here. Extensive disseminated pulmonary, and here it was non-severe extrapulmonary. So here it will be severe extrapulmonary, and pre-extensively drug resistance. That means fluoroquinolone is also resistance. So these have been classified into these two groups. So coming to the first group, this is a less severe category. Less severe category means this will require a shorter therapy. Less severe category means this will require lesser number of drugs. So we have classified according to age group, less than 5 years, more than equal to 5 years. Why? Because two of the drugs, one is delamanid and another is bedaquiline, they cannot be used below 6 years or below 5 years. So below 5 years age group, we have to think about replacement of bedaquiline or delamanid or avoid those, and above 5 years we can very happily include those drugs. So less than 5 years, we have to include a drug from group A, we have to include a drug from group B. But do we need a group C drug? This is a non-severe scenario, so we may not need a group C drug. So we'll include group A drugs, group B drugs, and the therapy will be shorter. And less than 5 years we cannot include bedaquiline and we cannot include delamanid. So what do we do? Patient is rifampicin resistance. Initial therapy is HRJD. Can we give R? We cannot give R. So we can give other three drugs, that is H, Z and E. So we'll give that exactly H, Z and E. And next we'll add a first line drugs. So what is the first line drug that can be given below 5 years? That is moxifloxacin. Levofloxacin will not prefer below 5 years. We'll give above 5 years. So moxifloxacin. Next we'll have to include one group B drug, that is clofazimine. Next we may or may not include one group C drug, that is ethionamide. Similarly, in more than equal to 5 years, what do we do? We have to include obviously HZE. We cannot give R because R is resistant. We have to give one group A drug. Moxifloxacin will give below 5 years, but above 5 years we can happily give levofloxacin, and this is above 5 years. That means we can also give bedaquiline. So bedaquiline we have also given. Clofazimine will also give in this age group. Ethionamide will also give in this age group. So in the non-severe scenario, we have given one drug from each category. We have added bedaquiline above 5 years, and we have given the first line drugs except the drug it was resistant to, that is rifampicin. So what drugs are given here? HZE, moxifloxacin, clofazimine and ethionamide. Here HZE, levofloxacin, bedaquiline, clofazimine and ethionamide. Now coming to this scenario is a severe scenario. Severe scenario means more duration. Severe scenario means more number of drugs. So accordingly, we'll also classify this as less than 5 years and more than 5 years. Why? Due to the same reason. More than 5 years, we can happily use bedaquiline and delamanid. Less than 5 years, we cannot use bedaquiline and delamanid. But important thing to know here is that as this is a severe scenario, we will require a higher number of drugs. And we learnt that group A is a must. So we have to include all three. So we have to think group A, we have to include all the drugs because this is a severe case. But we cannot include bedaquiline in less than 5 years. So what are the drugs we will give in less than 5 years? We will obviously give levofloxacin and we will obviously give linezolid. And levofloxacin can be replaced by moxifloxacin also happily in this case, or the patient is a case of less than 5 years. Secondly, we'll give obviously a group B drug, that is clofazimine, but it is a severe case. So like group A, we'll give multiple group B drugs also. So that is cycloserine. And obviously, it is always better to add a group C drug, that is any group C drug. Similarly, in more than equal to 5 years, what we will do? So can we give all three? The answer is yes, because the child is a more than 5 years old case. So we can give levofloxacin, we can give linezolid, we can give bedaquiline, we can happy well give all three. We can obviously give both the group B drugs, that is clofazimine, cycloserine. Why we are giving all the drugs from group A and group B? Because this is a severe scenario. Why didn't we do that in this case? Because this is a non-severe or less severe scenario, and it is obviously better to add a group C drug to any regimen. So this is the algorithm for adding the drugs to the drug resistant tuberculosis. So to even fine tune that, in case of non-severe scenario, the requirement of drugs will be number will be less and duration will be less. So accordingly, a plan has been made. Intensive phase of 4 to 6 months and continuation phase of 5 months has to be taken. So total duration is 9 to 11 months actually. So total duration is 9 to 11 months. Initially in the 4 to 6 months, HZE has to be given, levofloxacin or moxifloxacin has to be given, bedaquiline has to be given depending on the age is more than 5 years or not, and clofazimine and ethionamide has to be given. In the continuation phase, we may not give isoniazid, and we will give levofloxacin and we'll give clofazimine. Less than 5 years, omit bedaquiline and change levofloxacin to moxifloxacin like we discussed. On the other hand, this severe scenario, the total duration is 18 to 20 months like I told before, and there is no role of first line drugs here, only second line drugs. So that is levofloxacin, bedaquiline if it is more than equal to 5 years, linezolid always, clofazimine, cycloserine, and it is always a good idea to add one group C drug. And less than 5 years, we have to remove the bedaquiline and preferably we add a group C drug. And in more than equal to 5 years, as we are giving bedaquiline all the group A, all the group B drugs, it is okay if group C drugs because it is group C, so less important. So what are the special considerations that have to be undertaken in drug resistant tuberculosis management? First thing is we learnt about INH mono or polyresistance treatment, that is 6 months duration, but I told it is range is 6 to 9 months. So in which particular conditions the duration has to be increased to 9 months? I told I will tell later. So this is the conditions: extensive pulmonary disease, uncontrolled underlying morbidity, extrapulmonary tuberculosis except isolated pleural effusion or peripheral lymph nodes, and intolerability to any drug regimen necessitating change. These are the four scenarios in which an INH mono or polyresistance case has to be given treatment for 9 months instead of 6 months. Next, we learned bedaquiline only has to be used for children more than 5 years old and more than 15 kilo in weight. Delamanin has to be used for children more than 6 years and only as a replacement. Dose of linezolid has to be tapered to 300 mg after the initial 6 to 8 months of treatment, and preferably the therapy should be entirely oral with no parenteral drugs. Doses should be changed with change in weight band. Suppose a patient had come to you with tuberculosis at 11 kilo weight, but now with treatment receiving for 2 to 3 months, the patient has now grown up to 16 months, 16 kilo. So the weight band has been changed. So the patient has to be given the doses according to the newer weight band rather than the older weight band. So always child-friendly preparation should be used. That means the medication should be dispersible or palatable. And in cases of TB meningitis, rather than imipenem cilastatin combination, it should better be used meropenem. So these are the various drug doses to be used in drug-resistant tuberculosis. First line drugs, second line drugs, group A, group B, group C, all those drugs. You can pause and take a note of all this. So what are the key learning points here? Drug sensitive and drug resistant tuberculosis, the main difference is the definition. So the definitions are important for classification into various groups. NAT, LPA, C and DST, all these things should be used for diagnosis of various forms of drug resistant tuberculosis. Always two samples should be sent initially in all the cases. First sample has to be tested at NAT facility, second sample has to be tested at C and DST facility. NAT facility tests for NAT, C and DST facility does three tests: first line probe assay, second line probe assay, and culture and drug sensitivity testing. We should always include 4 to 5 effective medications from group A, B, and C. Group A and B is must, group C is plus minus. Regimen and follow-up protocol are longer in drug-resistant tuberculosis than drug-sensitive tuberculosis. So we come to the end of our session here. We have gone through a lot. We have learned a lot in all these videos, all these classes. So as every year, we celebrated World TB Day on March 24th of this year, and the theme was yes, we can end TB. So the goal or the purpose of making all these videos was to create an awareness among the medical professionals about the recent guidelines of National Tuberculosis Elimination Program, the recent guidelines of which came in 2022. As we know, tuberculosis is a condition, the guidelines and the recommendations of which change from time to time. Some years back it was category 1, category 2, category 3, then category 3 was removed, then category was removed, then new case, old case, now also that is removed. So tuberculosis management is very dynamic. It may change from time to time. So it's very important to stay updated about what is the recent recommendation for management of tuberculosis. so that we can always follow an appropriate regimen, appropriate protocol. And whenever in doubt, we should always seek help, seek professional experts, seek professional opinion. Our counterparts in pulmonary medicine department, our counterparts in general medicine department, they all are experts. Pediatricians are also experts. So in difficult cases or confusing cases, we can take their help. We should always take their help. And if we follow the guidelines, if we understand the basics, I think we can achieve our goal, or we can go a step closer to achieving our goal of ending tuberculosis. Some complicated topics are there in tuberculosis. I have made it, I have tried my best to make them as simple as possible. So if you like these videos, if you like these classes, press like, share with your friends, share with your colleagues, share with your juniors and seniors, share with your teachers, share with your faculties. If you have any suggestions, if you have any feedback, you can always post in the comment section and you can contact me and I'll be happy to help. Also, if you have any suggestions about future videos and what are the confusing concepts or confusing things that you want me to make videos on, you can always tell, or you can always suggest in the comment section. And if you find this helpful, subscribe to my channel for more such videos in the future. Thank you everyone. Have a nice day. Let's take our step towards ending tuberculosis. Thank you.